Hello, everyone. So my name is Yan. I'm a epidemiologist from the US FDA. And we have Dr. Ward Gardy, a solid organ transplant clinical pharmacist, as well as a drug safety specialist from the Department of Pharmacovigilance at the Saudi Food and Drug Authority. She will co-moderate the session with me. So today we have 9 posters. Okay, great. Today we have 9 posters covering a wide range of study types, but they all have one common theme, the drug-drug interaction. But I hope we will not only have interactions from drug, but also interactions from people between the audience and the presenter. So before we start, I want to announce some basic housekeeping rules. So we have 9 posters. Each presenter will got 3 minutes to present, and then we will have 2 minutes for 1 or 2 questions. So you can unmute yourself to ask the questions, or you can type your questions in the chat box. If we cannot finish answering all the questions, we can discuss these unfinished questions at the end of our session, or the presenters can type in the answers in the chat box. Okay, so let's start. Our first speaker will be Yue Chen from University of Kentucky.
Hi everyone, let me share my screen very quick here. Okay. Can you guys see my screen well and hear me well?
Yes, we can see your screen.
Great, okay. Hi everyone, my name is Yue, and today I'm going to present drug utilization and prescribing pattern of concomitant use of enzalutamide and anticoagulation. So enzalutamide is a drug indicated for prostate cancer. This population are more likely to be old and also at higher risk of developing complications which require anticoagulant treatment such as atrial fibrillation AFib and venous or embolism VTE. However, enzalutamide could have interaction with some typical types of anticoagulants like albiexidine and rivaroxaban, and have potential harmful effects on patients. For this study, the objective is to determine the incidence and characteristic of the concomitant use. This study is a retrospective cohort study, includes patients who have more than one outpatient pharmacy claim of enzalutamide between 2012 to 2018, using IBM market screen database. The index day is the first field day of enzalutamide prescriptions. We require a patient have more than 12 months continuous enrollment with no enzalutamide use pre-index. Also, patient will follow from index day until the end of enzalutamide prescription, the study period, or the enrollment. For the concomitant use episodes, as shown in the figure 1, I use consecutive prescription sets of both enzalutamide and anticoagulation to build the concomitant use episodes. As you can see in this figure, we require more than 7 days, at least more than 7 days concomitant use as concomitant use episode. If the gap is greater than 7 days, it will contribute to a separate episode. And overall, in this study, we identified 4,742 patients who prescribed enzalutamide. Among those patients, 229 of them are in the contraindicated group, which with concomitant use with albiexidine and rivaroxaban, and 393 of them is in non-contraindicated group with other commonly used anticoagulants like warfarin and heparin. Also, more specifically, the incidence of concomitant users is about 13 per 100 enzalutamide users, and the incidence of contraindicated concomitant users are about 4.8 per 100 enzalutamide users. And I summarize the baseline characteristic in table 1. The average age is similar in contraindicated and non-contraindicated group. And the average duration of the concomitant use episodes here, both of the group is about 75 days. Also, patients with VTE, which include pulmonary embolism and deep vein thrombosis, are similar in both groups. Patients with atrial fibrillation is higher in contraindicated group. One thing I want to point out here is if you look at the blue line in figure 2, the trend of contraindicated concomitant use is increasing over the years. One reason of this could due to the more commonly used of Abiexpan with oral Axiban because they are direct oral anticoagulants and it's more user-friendly than other anticoagulants. Overall, enzalutamide concomitant use with anticoagulants are pretty common in clinical practice. Future studies should be conducted to assess the potential harmful effect of the concomitant use. Thank you.
Okay, thank you, Yue. So I didn't see any questions in the chat box. So I have one question. So you used 7 days to define the concomitant use. So have you tried other threshold, and are your results sensitive to this different threshold?
For this study, for concomitant use date, right now we use 7 days. We discussed this with clinicians. We use 7 days for now. In the future study, we might try other thresholds in sensitivity analysis. But for now, I only use 7 days.
Okay, thank you. Okay, let's move to next speaker. So it will be Emily Acton from University of Pennsylvania.
Fantastic. Let me just. All right. Can you all see that okay? And can you hear me okay?
Yes.
Oh, fantastic. Right. Let's get zoomed in. Okay, perfect. So hi, everyone. My name is Emily Acton. I'm an epidemiology PhD student and medical student at University of Pennsylvania. And I'm going to be presenting on our team's work on opioid drug-drug-drug interactions and unintentional traumatic injury, screening to detect three-way drug interaction signals. So as this audience is well aware, in general, when we talk about drug-drug interactions, much of what is currently known is theoretical. And despite the majority of research focusing almost exclusively on pairwise interactions, we know that there are growing polypharmacy rates worldwide, making higher order interactions an increasingly critical consideration. Recognizing this, we developed and implemented in real-world data a novel approach to screen for three-way drug interactions, here abbreviated 3DIs. Specifically, building on prior evidence of the importance of opioid interactions in the risk of unintentional traumatic injury, we aim to identify signals of opioid 3DIs with commonly co-dispensed drugs leading to unintentional traumatic injury using semi-automated high-throughput screening. In this study, we conducted thousands of self-controlled case theory studies using 2000 to 2015 Optum Clinformatics data. And as the figure shows, each individual served as their own control, with a requirement that each had at least one unintentional traumatic injury event during observation. As you can see, 3DIs were then identified by examining rates of unintentional traumatic injury during time exposed to just the base pair, which was composed of the opioid and a potentially interacting precipitant indicated by the light gray line, versus time exposed to that base pair on top of an additional potentially interacting precipitant, the candidate precipitant indicated by the dark blue line. We used conditional Poisson regression to estimate rate ratios adjusted for dynamic confounders and semi-Bayes shrinkage to address concerns of multiple estimation. For brevity, what's shown on the slide are the three most commonly used opioids we assessed: hydrocodone, tramadol, and oxycodone. Among these three, we found a total of 174 signals for potential 3DIs based on significant positive associations with traumatic injury. The volcano plots here are shown to illustrate the multitude of potential 3DIs assessed with those data points in the upper right quadrant indicating statistically significantly elevated rate ratios, which ranged in these cases from 1.38 to 2.86. So to summarize with this study, we aim to serve or provide a foundation for future research in this area. This is a novel approach to screen for three-way drug interactions that does not require a priori hypotheses regarding those anticipated interactions, and it has broad applicability across drug classes and healthcare databases. And specifically for the 3DI signals found, these can serve as critically needed guideposts for future hypothesis generation and building of future etiological investigations. All right, thank you so much and excited for any questions.
So any question for Emily?
I have a question if we have time. This is really great and really interesting, and I'm really excited that you guys are doing this work with the 3D interactions. So the question I have, one is a clarifying, I guess, even using the figure that you already have on the slide. So you have, for example, tramadol plus duloxetine. Let's say that clarithromycin shows up as a signal, right? So in your analysis, you're comparing tramadol plus duloxetine plus clarithromycin to tramadol plus duloxetine, right?
Yes.
Is that okay? So how do you know it's a 3D interaction as opposed to just kind of like clarithromycin interacting with tramadol?
That is an excellent question. And it's certainly a possibility that that could be some of the issue, that in some cases, what we might be seeing is the candidate precipitate interacting with just one component of the base pair. What we can point to, though, is when we looked at our list of signals, a lot of them just made sense, either based on biological mechanism or the limited prior epidemiological data, that these would be three-way drug interactions. Things like 3 CNS depressants occurring together, or 2 CNS depressants and a drug that's known to have orthostatic properties, or other such combinations where you'd suspect that it was logical that there would be a three-way drug interaction occurring. Although certainly, as you said, that is a potential concern and it could have contributed to some of the signals that we saw.
Perfect, thank you.
Okay, then let's move to next speaker, Amir Sarayani from University of Florida.
Thank you very much. Let me share my slides real quick. Do you see my screen?
Yes.
Okay, thank you so much. I will get started. So I will zoom into specific sections to make it more readable for you all. We all know that combined oral contraceptives are known to be susceptible to CYP3A4 induction and potential decrease in their efficacy. However, there are some clinical opinions out there that suggest specific progestins in these products might be less susceptible to interaction because of pharmacokinetic parameters like longer half-life. Therefore, we aim to evaluate comparative effectiveness of combined oral contraceptives with respect to their progestin type when they are concomitantly used with anti-epileptic drugs that are known to induce CYP3A4 induction. We used a database of commercial health insurance plans in the United States to conduct a retrospective cohort study. We identified women of childbearing age who were using AEDs of interest that are known to induce CYP3A4, and also COCs of interest that had either of these 4 types of progestins. We followed up patients for up to 3 years of follow-up and identified pregnancy events during the follow-up period with an algorithm that is referenced in reference number 2. We conducted propensity score analysis to adjust for measured confounders, and we did a negative exposure analysis with drugs that are known not to induce CYP3A4 to see if there are sources of residual confounding in our study. As you can see in the results section, we identified roughly 80,000 cases across the 4 groups of progestins. Propensity score method was successful in adjusting for measured confounders. Some of them are provided here, and this is the before propensity score estimates, just to show how the cohorts look like. And in table 2, you can see the estimation for the rates and the rate ratios. And we saw that the norgestimate products are actually showing a higher rate of failure. And then the second rank was drospirenone, and the third rank was norethindrone compared to the reference group of levonorgestrel products. And those LNG products showed the lowest rate. In the negative exposure group, as you can see in table 3, we saw that drospirenone and norethindrone products showed similar rates of failure compared to the reference group. But however, norgestimate products were still showing higher rates of failure. However, the magnitude of effect was relatively smaller than the main study. In our team, we had pharmacometricians who did the calculations of fraction metabolized via CYP3A4, and we think that their estimations were roughly between 30 and 60%, kind of consistent with our findings. However, we need larger sample sizes to be able to break down the AED group to be more specific about the type of anti-epileptic and specific about the progestin doses, which all of them are the factors that we can allow us to replicate their study design in our type of data. And we should be kind of reflecting on the fact that we see some residual confounding potentially for the norgestimate. We consulted with clinicians and also clinical pharmacologists from industry, and the consensus was that these products are cheaper on the market and therefore they are channeled toward patients with lower SES, and we didn't really have the appropriate data to adjust for SES, which might be a factor for higher failure rates. And from clinical standpoint, I would like to mention that probably if patients really need to use COC products while they are using anti-epileptics that induce 3A4, they might be able to use LNG products to have a less likelihood of failure. However, we need further studies to replicate these findings. Thank you very much. Happy to take any questions.
Okay, thank you, Amir. Any question for him? So I kind of wonder, so in your study, you consider the progestins. So have you looked at the influence of estrogens contained in these oral contraceptives? Maybe the dose, yeah, especially the dose.
For this analysis, you know, the dose of the estrogen in these products varies between 20 microgram to 50 microgram. I mean, 50 microgram is the higher end, which we excluded those type of progestins. But between 20 and 30, we really didn't differentiate because as I mentioned, you see that the confidence intervals are still wide. And the other fact is that the main physiologic effect for preventing pregnancy is more attributed to the progestin component and not the estrogen component. So that's why we were more focused on the progestin type in this study.
Mm-hmm. Thank you.
Welcome.
Okay, so now let's move to the next presenter, Antonios Douros from McGill University.
That's me. Hi all. I'm gonna share my screen. The title of my talk, of my poster, is Effectiveness and Safety of Concomitant Use of direct oral anticoagulants, DOACs, and antiplatelets in patients with venous thromboembolism, VTE, an international multi-database cohort study. And as you can see, we have updated the title because we now show the final data of our study. So as most of you know, patients with VTE often have cardiovascular comorbidities, and as a result, up to 10% of patients are prescribed antiplatelets at the time of VTE occurrence to treat these comorbidities. Still, there is scarce evidence on the effects of DOACs in VTE patients who also use antiplatelets. And so guidelines do not include specific recommendations for this high-risk population. So the aim of our study was to assess the effectiveness and safety of concomitant use of DOACs and antiplatelets among VTE patients seen in routine clinical practice. To this end, we conducted an international population-based cohort study using administrative healthcare data from Quebec in Canada and in Germany. And our study cohort included adults with an incident VTE between 2012 and 2015 in Quebec or 2019 in Germany who initiated a DOAC or a vitamin K antagonist, a VKA, within 15 days of incident VTE while receiving antiplatelets. We use an attributed exposure definition, and then we applied propensity score based inverse probability of treatment weighting for confounding control. So we basically weighted the cohort and then we ran the Cox models in the weighted cohort to get hazard ratios and confidence intervals of the three study outcomes, which were recurrent VTE, major bleeding, and all-cause mortality associated with concomitant use of DOACs and antiplatelets as compared to concomitant use of VKAs and antiplatelets. That was the active comparator. And then we meta-analyzed the site-specific estimates using random effects models. Finally, we conducted exploratory secondary analysis stratifying by age and sex. So our study cohort included roughly 5,000 patients with an incident VTE initiating a DOAC or a VKA while being exposed to antiplatelets. And most DOAC users were rivaroxaban users, and all baseline covariates were very well balanced between exposure groups. As you can see in table 1, there was a similar effectiveness and safety between concomitant use of DOACs and antiplatelets and concomitant use of VKAs and antiplatelets, with all weighted hazard ratios being close to 1, and and with all confidence intervals, including the NOT. Finally, we observed a possible effect modification by sex, not by age, with more favorable outcomes for DOACs and antiplatelets in male patients for major bleeding and all-cause death, while stratifications were not feasible for recurrent VTE. So what about potential limitations? Residual confounding is possible, as in any observational study, and outcome misclassification is also possible, mostly regarding recurrent VTE, which can be hard to capture using administrative data. And finally, the fact that secondary analyses were based only on few events. So to summarize, we observed no differences in the effectiveness and safety between DOACs and VKAs among VTE patients who concomitantly use antiplatelets. But given the known advantages of DOACs over VKAs, our results support the use of DOACs in VTE patients who require dual antithrombotic treatment. So that was it. Thank you very much, and I'll be happy to answer any questions.
Thank you, Antonio. So any question for him? So I wonder, can you justify your use of random effect meta-analysis model?
Yes, that's a very good question. I mean, we use the same protocol. We didn't share code. There were different analysts in Germany and in Quebec, but there are things like formulary restrictions, for example, that we know of in Quebec, or differences in populations, which justify, I think, the use of random effects models. We also did a sensitivity analysis with the other approach, where I forget the name now, and we didn't see any difference.
Sure, thank
Fixed
you.
effects models, sorry.
Yes.
Now I got that. Okay.
Great.
There is, Antonio needs more data. Yes, although we use two different databases, some of the analysis were underpowered, especially the secondary analysis. So we definitely need larger studies.
Yeah, or good point.
Okay, thanks, Kate. Yes,
thank you.
You can check with your northern neighbors, you know, to see if they have any more data.
With my northern neighbors.
Oh, southern neighbors. Yeah, it's a long day. It's a long day. Sorry.
Polar bears. I have polar bears in the north.
Yeah, polar bears won't have it.
Okay. Yes. Okay. Thanks.
Okay. So, Bart, do you want to take the lead?
Okay.
Okay, great.
Okay. So thank you, Dr. Yan. I will introduce our next speaker, Yonghee Nam from the Department of Population Medicine at Harvard Medical School. So you can start now.
Yeah, hello everyone. Can you hear me?
Yes.
Hello. Yes, great. Yan, would you mind sharing my poster for me?
Okay, Dr. Yan, can you do that, please?
So can we move to the next speaker, because I switched the laptop. Yeah.
It sounds great. Thank you.
Just a second. So,
oh yeah,
Dr. Young?
Yeah,
I will try to.
So we can see you. Yes.
Okay. Is it clear now?
Yes. Could you zoom out a little bit?
Okay. I'm sorry, I'm not really good with using this.
Yeah, it's okay. Yes.
Okay,
so
I'll just try
hello
to.
everyone. My name is Yonghee Nam. I'm a research fellow at Harvard Medical School and Harvard Pilgrim Healthcare Institute. It's my pleasure to present our study that examined the association between serious hypoglycemia and calcium channel blockers, or CCBs, used concomitantly with insulin secretagogues. Serious hypoglycemia is a major and potentially fatal adverse event that can be caused by insulin secretagogues. It's clinically important, and insulin secretagogue-related hypoglycemia is one of the highest priority target areas to reduce adverse drug events. Insulin secretagogues are widely used in patients with type 2 diabetes, and many of the insulin secretagogue users have cardiovascular comorbidities and are receiving CCBs. Although there have been case reports that suggested potential benefits of CCBs in reducing the risk of serious hypoglycemia, the association between serious hypoglycemia and CCBs used in insulin secretagogue users remained unclear. We conducted a population-based observational study on the hypothesis that concomitant CCB use in insulin secretagogue users may be associated with reduced rates of serious hypoglycemia, because insulin secretion in pancreas involving calcium influx in beta cells can be inhibited by CCBs. We used Medicaid claims data from 5 U.S. states from 1999 to 2011, supplemented with Medicare claims for dual enrollees, and the self-controlled case series design, which inherently controls for measured and unmeasured time-invariant confounders. We additionally controlled for time-varying potential confounders in the statistical analysis. We used insulin secretagogues as object drugs or affected drugs, CCBs as precipitant drugs or affecting drugs, and metformin as a negative control object drug. Observation time, defined as a period covered by object drug prescriptions, was constructed for each object drug. The outcome of interest was hospital presentation for serious hypoglycemia identified by an ICD-9 clinical modification discharge diagnosis code-based validated algorithm. We calculated confounder-adjusted rate ratio for serious hypoglycemia with versus without concomitant CCBs using conditional Poisson regression. If you can move to the results section, yes, there is a figure. The results are presented in the figure. The vertical axis shows adjusted rate ratios for serious hypoglycemia. The rate ratios were statistically significantly reduced with glimepiride, glipizide, glyburide, and metformin. The rate ratio 0.79, for example, indicates that a point estimate for the serious hypoglycemia occurrence rate during the CCB exposed time was 21% lower compared with the rate during the CCB unexposed time when other factors were held constant. The rate ratios with meglitinides were reduced, but the 95% confidence intervals included a null value. So now the conclusion parts. Now these results suggest that CCBs used with insulin secretagogues are associated with reduced rates of serious hypoglycemia compared with the use of insulin secretagogues without CCBs, which can inform physicians in cardiovascular drug choice for the treatment of patients receiving insulin secretagogues. These findings also suggest that it may be important to monitor if glucose control is sufficient without dose adjustment when glucose-lowering medication users are receiving a CCB. Okay, I'll stop here. Thank you.
Thank you very much. Do you have any questions?
I guess I can ask my question. So thank you. This was really great. My main question is about what you're observing in metformin users. So it looks like in metformin users, CCB was associated with a protective effect. Is this something that was expected? And if not, what does it mean for the rest of the analyses?
That's a great question. We didn't expect this because the reason that we use negative control object drug is to help us gain information about intrinsic effect of precipitant drugs, because we were not aware of any pharmacokinetic or pharmacodynamic mechanisms by which metformin can interact with other drugs in terms of the effect of on the serious hypoglycemia outcome occurrence. So that we used metformin as a negative control object drug. But if you see our results, the rate ratios for serious hypoglycemia with metformin was statistically significantly reduced. So these results suggest that there may be some intrinsic effect from CCBs. Metformin is mostly renally excreted, and they're not the metabolism involving CYP enzyme. So these results suggested that there's some intrinsic effect from calcium channel blockers, but we think that further studies will be needed to elucidate underlying mechanisms.
Thank you.
Okay, great. So I think we will move on to our next speaker, Charles Leonard, Assistant Professor of Epidemiology from the University of Pennsylvania. So
thank you.
Can you share your screen?
Thank you. Are you able to see that?
Okay.
Great.
Yes, it's clear.
Hi, everyone. I'm Charlie Leonard from the Perelman School of Medicine at the University of Penn. I appreciate your interest in our work on the population health effects of drug interactions with skeletal muscle relaxants. This work, as well as earlier work on opioid 3DIs presented by Emily Acton, is supported by my 5-year federal grant from the National Institute on Aging. So this work, our analytic pharmacoepidemiologic study, was motivated by the fact that use of muscle relaxants is rapidly increasing in the United States, and little is understood about the role of drug interactions in the known association between muscle relaxants and unintentional traumatic injury, a clinically important endpoint causing substantial morbidity, disability, and death. Acknowledging this, we conducted high-throughput semi-automated screening of Optum Clinformatics data to find signals of muscle relaxant drug interactions that may be associated with traumatic injury. In a series of thousands of self-controlled case series studies, a case-only with in-person cohort-based study design that is resistant to measured and unmeasured confounding by static factors, we generated, via conditional Poisson regression, adjusted incidence rate ratios for muscle relaxant plus concomitant drug pairs. For each muscle relaxant new user experiencing a traumatic injury, the contrast of interest was observation time exposed versus unexposed to the concomitant drug of interest. It's important to note that we utilized a semi-Bayes shrinkage procedure to account for multiple estimation and thereby minimize false positive signals. Among approximately 74,000 muscle relaxant users meeting inclusion criteria, we were able to study more than 2,500 unique muscle relaxant concomitant drug pairs. Approximately 0.5% of the 2,500 had statistically significant elevated incidence rate ratios for traumatic injury and were therefore deemed drug interaction signals. These signals can be seen in the upper right quadrant of the volcano plot presented here, with each dot representing a self-controlled case series study we conducted. Dots in red are especially noteworthy signals since they either have a large magnitude of association with traumatic injury, for example, methocarbamol plus lamotrigine, or were highly statistically significant even after semi-Bayes shrinkage, for example, baclofen plus morphine. In summary, our real-world findings generate hypotheses about muscle relaxant drug interactions that may be of clinical concern. We hope our identification of a modest number of potentially clinically meaningful signals will guide future etiologic work to confirm or refute our findings. Thank you.
Thank you very much. This is a really great topic, and it can really help us also in detecting potential drug interactions in future. Since I'm coming from a regulatory agency, we really need to use such methodology. So anyone has any question?
I guess I'm gonna take this opportunity to ask some really tough questions.
Thanks, Kate.
Kidding. All right, so yeah, this is really great work, and looking forward to reading once you guys publish it. So I think it just occurred to me, you're looking at an outcome, unintentional traumatic injury, that will sometimes lead to initiation of muscle relaxants. So how does that come into the picture, especially given, you know, the designed self-control case series that has some pretty strong assumptions on outcome-related censoring and exposure?
Yeah, that's a great point. And in particular, when you see this paper in print, which is hopefully soon, we do have some strong words about potential, you know, reverse causality and protopathic bias. In particular, we focused on precipitant drugs, for lack of a better word, since some of these can be pharmacodynamic interactions that may precede the diagnosis of a traumatic injury, and things like pregabalin for neuropathic pain, things like NSAIDs or opioids that might be used to treat, you know, pain from an injury that doesn't yet present, you know, to the hospital for an outcome of interest. So we've certainly issued caveats for some of these things, but I think your point is well taken here, that the object drug of interest can also be initiated in those same instances. Thanks for raising that.
So I just wonder, can you do something with the risk window, trying to tease that out, help that a little bit? Yeah, so, you know, I can tell you, I'm not going to remember the exact details of this, but I'm pretty sure what we did is for a given day's supply, for a given prescription, we did this for both object drugs and precipitant drugs. We advanced the follow-up, we artificially advanced the follow-up one day, such that an outcome of interest couldn't occur on the same day of initiation. And I'd need to think more through that if whether that addresses your question. But our thought process behind that was to give a little more leeway for muscle relaxant initiation that would occur on the same day as a traumatic injury event, because we wouldn't really know if it came before and precipitated it or came after as a treatment. Thank you.
That's like another, just a suggestion. So you might think through how it's going to operate, because, you know, if people initiate drugs after they have the injury, then theoretically this drug might show up as protective because the outcome will be counted during the unexposed time.
Unexposed time, yeah. And clearly you can see in the upper left-hand quadrant here, there were a number of protective signals.
Okay, thank you very much. So now we will move to our next speaker, Ainhoa Gomez. You may share your screen.
Sure. Okay. Let me please know if everybody can hear me and see my poster.
Yes, yes, it's very clear.
Perfect. So hi, everybody. I'm Ainhoa Gomez Lumbreras. And first of all, thank you for allowing our research to be in this session and for taking your time to hear about it. I'll be presenting this poster on behalf of my colleagues from the Merced University, University of Washington, University of Pittsburgh, and University of Utah. Let's get started with our lead actor in the drug interaction we focus our study, colchicine. Colchicine is an old drug used mainly for gout and familial Mediterranean fever, which in the last decades has seen its indication expanded in the cardiology, oncology, and immunotherapy fields. Colchicine has a narrow therapeutic window, and it's metabolized through the CYP3A4 enzyme and uses glycoprotein P as a transporter. Drugs inhibiting either the CYP3A4 or the PEP would increase levels of colchicine, and clinically, this could lead to more adverse events and more severe ones. Colchicine's most frequent adverse events are gastrointestinal, but there are some life-threatening and fatal adverse events described. So with the aim of identifying colchicine-drug interaction safety signals when concomitantly reported with a CYP3A4 and PGP inhibitor drugs, we use the FDA Adverse Event Reporting System database, FAERS, to conduct a case-on-case study in which we selected those reports from 2004 to 2020 containing the drug per colchicine and any drug inhibiting either CYP3A4 or PGP, such as clarithromycin, fluconazole, verapamil, or listed in the method sections down to the left. The reported outcomes are coded in FAERS using the Medical Dictionary for Regulatory Activities, MEDRA. So we selected the listed standardized MEDRA queries to capture all the adverse events we were interested in. Let's move to the results section. A total of 787 reports mentioned the drug pair of interest and the selected outcomes. More than half of the reports did not have colchicine listed by the reporter as having a suspected or interacting role in the adverse event reported. Subjects were in their 60s, more males. We could also be explaining for the colchicine pattern of use, and reporters were mainly medical doctors. Almost 200 reports listed deaths and almost 500 hospitalization as their severity. To estimate the safety signals, we use a disproportionality measure, the reporting odds ratio. This reporting odds ratio doesn't allow quantification of true risk, but it represents the odds of the reports with a specific event mentioning the drug pair of interest, in our case, colchicine and a CYP3A4 PGP inhibitor drug, compared to the odds of the same event being reported by the rest of the reports in the FAERS database. As we see in the figure, only 6 drugs from the initial list showed signals for rhabdomyolysis, and the drug per colchicine daltiazem showed significant reporting odds ratio for rhabdomyolysis and granulocytosis, hemorrhage, and acute renal failure, being the drug pair with more signals. To conclude, we will say that the strong signals in FAERS appeared when colchicine is concomitantly reported with a CYP3A4 PGP inhibitor drug, and that prescribers of colchicine must be alert for colchicine toxicity when concomitantly using these CYP3A4 PGP inhibitor drugs. Thank you for your attention, and I'll be more than happy to answer any question.
Thank you, Ainhoa, for this nice poster. So I was just wondering, did you face any challenges while using the FAERS database?
Well, the database, as you know, is a public dashboard, so we download all the data. There are some of the reports containing multiple outcomes. So we could have like more than one of the drug in each report from these CYP3A4 or PGP inhibitor drugs, and we didn't exclude them. But I mean, they are all listed, so that could be quite a challenge. Yeah.
Great, thank you. So does anyone have any other questions?
I have one question. Hi, very interesting study. So my question is about the disproportionality analysis. So basically, on the one hand, you have like at least 2 drugs of colchicine plus the CYP3A4 inhibitor. And on the other hand, you have everything else. No, if I understood it correctly. Yeah. So
right. Oh, sorry. I didn't mean to do.
Okay, like couldn't that be like a little? Couldn't that create like an issue because you will be comparing like 2 drugs versus 1, or like I'm trying to wrap my head around it because drug-drug interactions with pharmacovigilance data are a little tricky. Yeah?
Okay, yeah, I totally agree. It's not that we are looking for those reports only mention colchicine and no any other drugs, or only mention CYP3A4 inhibitors or PGP inhibitors. It's like the comparison. It's like those reports showing the interaction. I mean, mentioning colchicine and one CYP3A4 PGP inhibitor, and the rest of the reports can mention either one of the other, but not together at the same time. Okay. But they could be with any other drugs. I mean, okay. We selected those, but the reports could be having any other drugs. Yeah.
Okay. Thanks.
Oh, and I see in the chat, yeah, well, we are also trying to make this negative control, not only for the drugs, also for the outcomes of interest. So trying to analyze this with other standardized MEDRA queries and also to see if the signal arises. Yeah, totally agree.
Okay, great. Thank you, Anouar. So now it's time to move to our next speaker, Adrian Martinez from the Institute of Pharmaceutical Sciences from Switzerland. So can you share your screen?
You're muted.
Yeah, no, sorry, I was muted. So hello, thank you everyone. My name is Adrian Martinez and I come from the Federal Institute of Technology at the ETH Zurich in Switzerland in the pharmacoepidemiology group. And I'd like to talk today about acute generalized exanthematous pustulosis, also called AGEP, and an exploratory analysis on drug combinations. So in this research, we sought to investigate drug combinations associated with AGEP. And to understand what AGEP is a rare but severe skin adverse drug reaction. And this reaction is characterized by the sudden presence of several minuscule non-follicular pustules over an erythematous erythema. So it means like the body develops a rash, let's say, over the whole body. And more than 90% of the cases are associated with drugs, especially with antibiotics, with symptoms usually appearing in the first 24 hours from intake of the drug. In this case, we included 2,649 individual case safety reports of AGEP that reported more than one drug since the database inception to January 2021 from Vigibase, the WHO pharmacovigilance database. From these patients, almost 60% of the cases were in women, and the average age was 57, with an average number of reported drugs overall of 4.2. We identified that antibiotics such as amoxicillin, ceftriaxone, and clindamycin were the most commonly reported, also in drug combinations. And we can see this already if we look at table 1 with the different combinations, the drug-drug pairs and drug triads of combinations of drugs that were more frequently reported. Overall, 62.1% of the individual case safety reports included at least one antibiotic, and amoxicillin was the most frequently reported drug. Interestingly, what we saw that has not been discussed in the literature is that there were a lot of that cardiovascular drugs were reported very frequently. So, for example, antithrombotic agents like clopidogrel or heparin, or calcium channel blockers like amlodipine or lercanidipine, or even beta blockers such as bisoprolol or metoprolol, they all appear here, were reported in 1/3 of the patients. So at around 33% of the patients had taken cardiovascular drugs. To confirm or to investigate further this hypothesis that we came up with, we conducted a network analysis, which we can observe here, one of the clusters, in which we applied the 2 different cluster algorithms in order to obtain the different combinations of drugs that were most frequently reported. Then we observed that the thickest edge in this cluster analysis, all the thickest edges were among cardiovascular drugs. And for example, the largest one was between acetyl salicylic and atorvastatin, or the furosemide with bisoprolol. So the bottom line is that our study is the largest real-world assessment of drug combinations associated with AGEP. All the literature so far is based on case reports and a few observational studies. We show that cardiovascular drugs or underlying cardiovascular disease might be associated to AGEP onset. And we acknowledge that our study and our approach has important limitations, for example, by using a pharmacovigilance database. But I think that we are opening a new path of research. We are generating new hypotheses to investigate further if really cardiovascular drugs or underlying cardiovascular disease could be associated with AGEP. So thank you very much for listening to me, and I hope you have questions. Thank you.
Thank you, Adrian. So anyone has any questions? So looks like I'm going to ask you a question. And I would like to know more if you can elaborate on the algorithm that you have used in your network analysis.
Yes, absolutely. So the algorithm, the way it works, first you construct a network per patient. So you would see like all the drugs that this patient was taking concomitantly. So you would have the different nodes or the balls, let's say, would be connecting to the drugs that that the patient was taking. And then you would aggregate this to the population level. So you would aggregate all the different nodes with the different connections or the edges to construct the network. And then once you have constructed the network, what you do is a clustering algorithm, which is we use the Louvain algorithm. And what we are trying to find is the community structure to see if there are certain drugs that are heavily connected, and then we can disentangle and we can separate them. So then that's how we observed, for example, that certain drugs were very frequently connected to each other, meaning that they were reported into the pharmacovigilance centers that these patients have taken the drugs concomitantly when AGEP happened.
Okay, great, thank you. So I think there's another question from Yan. What's the software you use to draw the graph?
Yeah, well, for the analysis I used R, and for this graph I used Gephi. I can write the name, and it gives very nice plots, and it can allow to have a very let's say interactive way of playing with the graphs. I can try to zoom in now. If you like, you can see the edges better if you zoom in, and well, the cool thing is working with the interactive plot, because then you can really move the different nodes around and can see the connections better. You can highlight.
Yes, exactly. I can imagine that. Thank you very much
You're
for
welcome.
this nice poster. So now we will move on to our last presenter, Alvi Rahman from the Department of Epidemiology, McGill University at Canada. So can you share your screen, please?
Just a second. Is my presentation visible?
Great.
Perfect. Thank you so much for being here. Good afternoon, good evening, everyone, wherever you are. So I'm here, my name is Alvi, I'm a PhD student at McGill University, and I'm here to present a project for my thesis, which will be assessing the association between the risk of major bleeding and the concomitant use of selective serotonin reuptake inhibitors and oral anticoagulants. And this was a systematic review and meta-analysis. So just to provide some background, SSRIs are a class of antidepressants that have been associated with a modest increase in the risk of major bleeding. This is possibly due to their effect on platelet function. And this risk may be substantial in patients who are already using oral anticoagulants. Thus, the objective of this review was to estimate the risk of major bleeding associated with the concomitant use of these two drugs compared to OAC use alone in adult patients. So for the methods, we searched the 4 databases that are listed here according to the eligibility criteria that are provided, and this was based on the objective of the study. As in most systematic reviews, there were 2 reviewers who conducted title, abstract, and full text screening, and the same 2 reviewers also conducted risk of bias assessment using the Robbins I tool for Cochrane. However, we adapted this tool by adding an additional domain that considered specific biases in pharmacoepi, like time-related biases or prevalent user bias. And then we had also planned a random effects meta-analysis, and this was given sufficient homogeneity of studies. And given that there were enough studies, we had also planned secondary analyses according to effect modifiers and some pertinent secondary outcomes. So in our study, following screening, we ended up including 14 records in the systematic review. And among these studies, 8 were deemed to be clinically and methodologically homogeneous, hence these were included in the meta-analysis. So to provide an overview of the studies that were included over here, these studies are categorized according to whether their primary or secondary objective coincided with the objective of this review, and it was split in half. The studies were either cohort or nested case control study, and typically the populations were patients who were initiating oral anticoagulants. Different types of bleedings were were assessed in these studies, and the limitations in these studies typically included exposure misclassification, sometimes residual confounding, as in most observational studies, and also prevalent SSRI and or OAC use. So for our meta-analyses, as I mentioned, we pooled 8 studies that were deemed to be homogeneous, and we found that the risk of major bleeding increased by 35% in patients using SSRIs and OACs concomitantly compared to OAC use alone. Unfortunately, there weren't enough studies to assess all of the effect modifiers or meta-analyze all the effect modifiers that we wanted to. And for the ones for which we did have some information, uncertainty was rather high. However, we were able to pool results for patients who were using DOACs. So among patients who used DOACs and SSRIs concomitantly, there was a 47% increased risk of major bleeding compared to DOAC use alone. So overall then, in patients using OACs, the concomitant use of SSRIs significantly increased the risk of major bleeding, and physicians may need to tailor treatment when prescribing SSRIs to patients using these drugs. Future studies should focus on identifying specific patient groups at higher risk, and there's more promise that this can be done now given further availability of data. Thank you so much for listening, and I'm happy to take any questions.
Thank you very much. Very nice presentation. So anyone has any question?
Yeah, so thank you so much. This was really interesting. So I'm looking at table 1, and from what I'm seeing, all the studies kind of focus on patients who initiated DOACs. So where...
Sorry, I did catch you.
Yeah, so where does the concomitant use with SSRIs come in?
So typically how these studies were designed was that they started off with patients who used, the older studies would be with patients who started using warfarin. And from the newer studies, we see more where patients initiated DOACs. And then these patients were followed up over time, and they checked to see whether or not these patients had initiated SSRIs during follow-up, upon which they would be considered concomitantly exposed.
None of these studies actually specifically evaluated the interaction, right? So it's more kind of subgroup analysis.
It's more, so it was assessing, most of these studies would be assessing concomitant use versus the use of the object drug alone, which was OACs in this case.
Got it. Yep, got it.
So I wonder, have you distinguished the studies that evaluated the precipitant triggered versus object triggered kind of interaction?
So typically, most of the studies that we found in this case were object triggered, as patients that were included in most of these studies, as Dr. Baikov mentioned, were patients who had initiated on DOACs. Or OACs, sorry, and they were only followed up for as long as they were using OACs. Hence, once they stopped using OACs, their follow-up ended. Thus, for those studies, for the most part, they were all precipitant triggered concomitant use. However, there was one study, so this is the one by my supervisor. So in this one, the concomitant use was a secondary objective. The primary objective of this study was to look at the association between SSRIs and intracranial hemorrhage. And there was also secondary analysis conducted with patients who were also using oral anticoagulants. Hence, in this case, there's a possibility that some of the patients could have been object drug triggered, but this wasn't distinguished in the study as it wasn't the primary objective.
Thank you.
Okay, great. So anyone has any other questions? Thank you everyone for this nice session. So Dr. Yan, do you have any comments?
So looks like we have a lot of interactions here today.
Yes.
Just want to mention there is a ICP special interest group for drug-drug interaction. So you can find that on the ESP Exchange. So we have a lot of activities such as journal clubs and others. So you're welcome to join. Okay, so, okay, Kate, do you want to say something about?
Well, I wanted to thank everybody. And also, I believe this was recorded in case anybody wants to rerun again and listen to all the presentations. And thank you to presenters, and thank you so much for moderators. You guys did a great job.
Take care, everyone.
Thank you all.
Bye, everyone.